Welcome everyone, and thank you for joining us today as Cambia Grove's 2020 Innovator Fellows present the work that they've done and recommend next steps to advance data interoperability in the healthcare system. I'm Julie Anderson, Director of Strategic Initiatives at Cambia Grove. At Cambia Grove, we seek to advance innovation in healthcare towards a person-focused and economically sustainable system. We do this through collaboration with the 5 points of healthcare, which are patients, payers, providers, policymakers, and purchasers, as well as with other aligned stakeholders and innovators. Our goal is to support impactful innovation by developing healthcare innovation ecosystems across the country. Part of my role in this work is to oversee the Solutions Lab, which is an initiative aimed at breaking down barriers to innovation. In 2018, the Solutions Lab dove into the topic of data as a critical component of the infrastructure required to drive healthcare innovation. As part of this work, we zeroed in on interoperability as a clear and high priority barrier for us to tackle. After further research about how best to dive into this important topic, we developed the concept behind the fellowship program. Our goal was to enable innovators to take a deep dive, a firsthand look into issues like interoperability, seek strategies to overcome obstacles, and then to share findings with the community at large. This year, we partnered with incredible mentors, in addition to countless individuals who were interviewed for their subject matter expertise. We would like to thank our partners who included OneUp Health, Cambia Health Solutions, the Karen Alliance, the Da Vinci Project, the Gravity Project, Health Samurai, HL7.org, Humana, Multicare, OHSU, Seattle Children's Hospital, and UHIN. These 10 fellows have spent the last few months really digging into interoperability. And during our time here today, we are so excited to finally hear from them about their learnings and their recommendations for how to move forward. As they present, please post your questions in the Q&A box located at the bottom of your screen. We have about 5 minutes in between each presentation for questions, and I will get through as many of them as I can. Finally, as an FYI, this event is being recorded and will be made available after we wrap up. Okay, so without further ado, I am honored to introduce the first presentation of the day on the CMS Patient Access API rule. Would Mike, Aju, and Daya please turn on your videos and join me on stage? Wonderful, welcome. Okay, so Mike, I understand you'll be sharing your screen. Fantastic. Yes. Just do a quick round of introductions, your first and last names and affiliations, and then go ahead and take it away. Good luck.
Thank you, Julie. Yes, my name is Michael Barabee. I'm the Enterprise Data Architect for the Washington State Healthcare Authority.
My name is Aju Jacob, and I'm the Enterprise Architect at Blue Cross Blue Shield of Tennessee.
Daya, you're on mute.
Thank you. I'm Daya Sharma, the CTO of the Handoff Company.
Great. So yeah, as Julie said, we're here to talk about the CMS Patient Access API rule and its impact on payers and some of the future forward-facing things that payers can look at when leveraging their FHIR architectures. So our agenda, really quick, we're going to talk about some background, how we got here, some of the challenges and impacts, and the focus of our work. How we approached the work in the project that we did, what our findings were ultimately, and then also potential reference architectures and solution approaches that payers could take. And then ultimately, where do we go from here, forward facing into the future. So some background, as we know, interoperability has advanced quite a bit over the past decade. Most of that advancement has been through CMS and ONC's regulatory authority. And then also some financial incentives that have been provided to move interoperability forward. A lot of the early focus, of course, was on providers and implementing or improving their EHR capabilities. But also, in parallel to all these regulatory improvements, there's been vast improvements in the standards themselves used to exchange healthcare data, and not the least of which is why we're all here, FHIR and implementation of FHIR. That occurred in 2014, and since then, FHIR has matured quite a bit, expanding on the resources. More resources are now in normative state, and all the way to the current version, which is 4.0.1. It also includes, claims and financial components, so data that, payers hold, in addition to, of course, the many clinical pieces of data. Also, in healthcare, we've advanced quite a bit in use of APIs, and CMS sort of set the tone for this back in 2019 when they implemented their CMS Blue Button API. And that, of course, that's a FHIR-based API that allows Medicare members to access their data using a third-party app of their choice. And then, of course, we've come to spring of this year. April of 2020 is when CMS and ONC dropped their final rules, and got us, now to this point where payers are looked to implement the Patient Access API rule. So when we talk about the rule itself, initially the implementation date was January 1st, 2021. CMS has pushed discretionary enforcement though until July 1st. So we've got a little bit more time to get that implemented. The rule doesn't apply to all payers though. It's only those that are under CMS regulation. So Medicare Advantage plans, state Medicaids, both fee-for-service, managed care, CHIP, and qualified health plans on the federally funded exchanges. Much like the Blue Button API that CMS uses, the APIs must be FHIR-based and also made available to any third-party apps that properly register and authenticate. So in addition, payers must implement registration processes. And besides the technical pieces, they also have to provide documentation. So documentation to the app vendors, and then also to educational materials for their patients, so they can better understand what they're doing when they allow an app to access the data that the payer holds. So some of the challenges and impacts, the impacts of the CMS and ONC rules go across the 5 points of healthcare, of course. But on our project, we really wanted to focus on both just the Patient Access API rule and its effect on payers. And one of the big impacts is that many payers are behind when it comes to technology and having a FHIR-based architecture. And I can tell you, that our agency, this will be our first implementation of a FHIR-based architecture. So we're really playing catch up on the technological side. But also there are important decisions that payers need to make from a legal perspective. So what data is in scope? What data is out of scope? They have to interpret the rule and ensure that they are complying with the rule. And there's some important decisions that have to be made before they even start their implementation journey. So our focus, again, for our project was not only the technological and the data perspectives, but also some of the business, legal perspectives, member experience, what are members going to experience when they actually see their data through a third-party app. But then also talking about what future possibilities payers can explore when it comes to their FHIR architecture once they have this implemented. So I'm going to turn it over to Aju now, and he'll talk to you through how we approach this work.
Thank you, Mike. So at a very high level, the approach that we took for our project could be condensed into a 4-step process as shown on the graphic on the slide. So one of the very first steps that we did was to start the interview process. So we interviewed various stakeholders from across the healthcare industry. We spoke to folks at different levels, CIOs and CTOs and analysts from across the healthcare spectrum to gather their inputs around the policy aspects, the business aspects, the data aspects, and the solution approaches that we are going to share with you over the next several slides. So after these interviews were completed, we try to identify patterns. So that's the next step in the process, the patterns. And that's where we try to condense the plethora of information gathered from these interviews. And this is where common themes and common opportunities and common solutions started to emerge from the detailed notes that we collected from these interviews. We then made sure that we validate these findings to make sure that they could be applied to a broader audience, because we don't want to publish something that's only specific to one person or one company. So we made sure that actually it applies to more than multiple different entities. And finally, we went through the documentation process, and this is where we documented the validated findings in a summary document that you all are free to use and share. And this document is going to be published on the Cambia Grow website. Next slide, Mike. This slide kind of speaks for itself, but we wanted to highlight and thank everyone who set aside time to share their valuable inputs with us. Again, like I mentioned earlier, we try to make sure that we gather inputs from across the spectrum. So you'll see payers, solution developers, application developers, fire experts, and providers, so that we understand the perspectives from across the industry. So thank you all. Next slide, please. So over the next few slides, we will walk you through our findings and the solution approaches that emerged from our interviews. So to begin with, we'd like to touch upon the business and member experience aspects of it. And first of all, from a legal compliance standpoint. So one of the key questions from payers was the extent to which they can actually vet a third-party application before they onboard this application onto their Fire APIs. Unfortunately, the answer to that question is not a whole lot, but payers can actually use attestations and disclaimers to guide and inform their members. And you will learn more about it actually at at our next webinar, which is at the end of the session, end of this 2-hour session. So the next on the list is allowing personal representatives access to a member's information, as well as the attestations and the disclaimers required to support this. This was a key consideration because some of these payers, they do not have a mechanism where a third party or a representative can actually get an account on the portal. So that's something that payers have to implement. And lastly, it's also important to analyze your subcontractor contracts to make sure that you're actually capturing all the data required by CMS and is made available through your Fire APIs. It again depends on how your contracts are structured, and it'll be based on the conversations you have with your legal partners. From a strategy perspective, it was very clear that we should not be approaching this just from a mandate standpoint, but really looking at it from the perspective of building a new capability that is most likely going to supersede EDI and X12 in the future. So it is very important for payers to stand up a strategic Fire capability and staff up the resources and skill sets needed to take this new capability forward. From a support standpoint, patient education materials as well as app developer documentation is a requirement from CMS. But in addition to that, we would say you need to make sure that you equip your customer service representatives with the training and the tools and the new policies and the procedures to support your members when they start using those third-party applications, starting from mid of 2021. And lastly, from a member experience standpoint, so we all need to keep in mind that we are actually opening up a brand new channel for patients to access their health information. This is in addition to the member portal and your payer-specific application that you have today. This is going to be a new channel. So things like offering a digital identity to bring all the member data into one login would help the members. And similarly, consent management. Even though CMS does not really require a detailed consent management, offering a self-service consent management so that patients can actually revoke consent to their data, revoke consent to consented applications. This would really benefit the user from a privacy and security standpoint. And also notifications. This is kind of like security emails or alerts to let members know that a third-party application has gained access to their data. So these things would really go a long way into improving the whole member experience aspect of interoperability. Next slide, please. And one of the main pain points from talking to the different payers and entities is the identification of data sources required to meet the CMS mandate. It's always a best practice. So what we heard is actually it's always a best practice to keep your legal and compliance teams in the loop, especially when you work on data maintained at subcontractors and vendors, as well as the data you collect for various other business functions, for example, utilization management, HEDIS scores, risk adjustment. So in some cases, actually, you may have to include clinical data from these business functions onto the Fire API. So you got to work with your members your legal team to actually make a determination on that. And secondly, once you identify your data sources, the next logical step in the process is to map the data from these data sources to the Fire resources. And this is, again, something you can do by yourself. Depends upon your level of expertise in Fire, or you can use one of the mapping documents like Karen CPCDS map to help you in the process. And we also got to make sure that we keep the data timeliness aspects of it in mind. So it may be a good idea to actually create a process flow documentation so that you can ensure that the patient's data is going to be available on the Fire APIs in a timely manner as required by the CMS mandate. Next slide, please, and I will turn it over to Daya.
Thank you, Aju. Now, there are different ways to implement a Fire server. But before we go into the architecture options, let us define what a Fire server is. A Fire server is any endpoint that can serve some for all types of API defined in the FHIR specification and can return, most importantly, a capability statement, which lists the server capabilities in terms of APIs, the resources, search parameters, and operations. There are orthogonal considerations to any particular FHIR implementation, and these are very common in most of the server implementations, and they center around identity and access management. And this is especially true for now that the CMS rule mandates third-party apps be allowed to access the patient data using OpenID Connect and Smart on FHIR. Then to support that, support the reliance on the server and application performance and management, APM, should be used, which is based on the logging and observing and monitoring for some kind of a malicious activity. So this can be used to enhance the security, and some of these attributes that go around creating a reliable FHIR implementation are automatically served by an API gateway. So these API gateways, some of them, they have built-in audit log support, which is mandated by the HIPAA, and even support things like API throttling for preventing denial of service attacks. And some of the examples of API gateway are Kong HQ, which is a open source and cloud agnostic API gateway, and FPG from the Google Cloud. Now, before any deployment, API testing, specifically to test the implementation guide validation, needs to be done. For that, Touchstone is a solution from Aegis that can be used to test the conformance to a particular implementation guide. So having covered these orthogonal concerns, let us now understand some of the key differences between the reference architectures, namely the repository and the facade pattern. Next slide, please. So the repository pattern is implemented easily by using a generic FHIR server, which comes pre-configured with a persistence layer that supports relational or document database. Some examples of generic FHIR servers are 8box from Health Samurai and Wonk, which is .NET based, and these are the commercial offering. And then there are open source offering like the Happy and the Smile CDR. Regardless of which server option is chosen, the repository pattern means data from legacy data sources or legacy stores will need to be migrated either on a periodical basis through some kind of a cron job, or in one shot at the go live time. In this pattern of implementation, the FHIR server then becomes the repository of truth, and consumer requests are served directly from the database in the FHIR infrastructure. Next slide, please. In the facade pattern, however, the source of truth, the data, remains in the legacy stores or the applications or API or even external data store. It is never persisted within the FHIR infrastructure. And the facade pattern is obviously used to implement some or all of the FHIR APIs and or the standard operations, depending on the particular use case. In this pattern, the data is fetched in real time from the legacy data sources, which means an initial mapping exercise has to be done for the real-time data transformation, so that the response can be served in a meaningful way. Now, depending on the number of consumers and the number of the data sources that exist in your organization, and the acceptable level of the latencies, the facade layer can be shifted to be nearer to the consumer or nearer to the data source layer. Or even a hybrid solution using both the facade and the repository pattern can be used depending on your specific use case. Next slide, please. And Mike will take it from here.
Thanks, Diane. So giving you a lot of information, a lot of things that payers need to consider when implementing their FHIR architectures and their solutions for the API rule. One of the things we all know, especially people like me that work for payers, is we're going to learn a lot in the next year. And it's important for payers to share that information across the spectrum of healthcare. Also, we want to acknowledge, the very many efforts that are going on right now with FHIR and the work groups, such as Da Vinci, the Karen Alliance, ONC Fast Tiger teams. All of these groups are putting out many, many, many more use cases that payers need to consider for future implementation, not just simply focused on the rule, but going beyond, and where payers can take their FHIR architecture once they have it implemented. So, payers need to develop, obviously, short-term plans to get compliant by July 1st of next year. But also, everything that we heard from our experts and the things that we take away is one of the big things is thinking more strategically and future-facing when it comes to interoperability and use of FHIR and the FHIR architecture they implement for the patient access API. I mean, just a handful of use cases, future use cases or potential use cases would be, around value-based purchasing, quality measures, prior authorization. We know how heavily manual prior authorization is with faxes and paper documents. Da Vinci already has a proposed solution for that using FHIR and APIs. And then also more exchange of data between payers and providers. So we think there's a lot of opportunity for payers in this space once they have implemented their solutions. So finally, we just want to say thank you to, first of all, Cambia Grove for allowing us to participate in this fellowship. The connections they made with our mentors there, mentors were great, supported us over the 3-month period. And then all the experts in interoperability and FHIR that we spoke to that we showed on our slide earlier. So we just wanted to thank you all, and that concludes our presentation.
Wonderful. Thank you all so much for sharing that summary with our community. We have some questions that we'd love to ask you with about 5 minutes that we have here remaining. I think I would just like for you to touch on the question of how did the 3 of you come together to form your team and to tackle this topic?
I can try to attempt that. So I think it started with a conversation with, I think it was with Mike actually. So Mike also works at a payer. So we had that payer thing in common. Mike works for Washington State Authority, and I work for Blue Cross of Tennessee. So we were actually talking about all the different challenges we have to face before we can actually implement these APIs by 2021. So then we were like, actually, why don't we try to document our findings? So that's when we tried to partner up, and then we ran this idea by Dea, and Dea was also very interested in the FHIR implementation aspects, and then so we went from there. I think that's the story. And Dea, Mike, you want to add anything in there?
Yeah, I think I would like to just add to that is that it was a very interesting thing for me because I do have some experience in implementing a FHIR capable, server, and so it was like interesting to expand my horizon and seeing what are the different implementation choices and the use cases that are specific to the payer world.
Yeah, I just echo everything that Aju and Daya said. I think for Aju and I, it's like we've got this right in front of us, right? So this is, we're really working hard on this, and we just saw it as a really natural way to align our day jobs with this fellowship and really bring benefit not to just our organizations, but to other payers as well.
Wonderful, thank you. And then another question pre-submitted. What advice would you give to others who plan to take a step into this world? What would you say to the innovator community from your learnings?
Go ahead.
Mike, you want to go?
Oh, you go first.
I think what I would say is think long term. So it's very easy to get caught up on the nuances of the CMS mandate, trying to rate the subcontractor contracts, trying to work with vendors and all that, trying to meet the mandate. But I would suggest that actually, look at it from a long-term standpoint, because fire is here to stay. EDI, EDI and X12 at some point is going to become things of the past. So when you work on this, actually think from the strategic standpoint and try to staff up and set up this foundation to enable you to actually get on this train, I guess. That's what I would say.
Yes, and I would like to add to it. First of all, don't be afraid of fire. And second of all, technology is, even though it is rapidly changing, there are so much happening in the open source world, and there is a convergence and a strong collaboration alliances that one can tap into to learn and adapt the different technologies out there and have a futuristic footprint.
That's great. Thank you all so much. Okay, I think that concludes the questions that we've received so far. Thank you so much to Mike, Aju, and Daya for your presentation. I would like to call our next presenter to the virtual stage. Would Kevin Williams please join me and pull up the slides that you've prepared? Hi, Kevin, welcome. And I would just like to quickly also say a quick reminder to the audience, please do share your questions in the Q&A box at the bottom of your screen. As I mentioned earlier, we've got about 5 minutes in between each of these presentations to get to your questions, and we'll get through as many as we can. So please do chime in throughout. All right, with that, Kevin, please just quickly introduce yourself and take it away.
Great, thanks, Julie. So my name is Kevin Williams. I'm a healthcare software consultant. I'm focused on big data applications and data standards. So today I'd like to talk to you guys a little bit about advanced care planning and fire. So advanced care planning is more important today than ever. Many people in the US nearing the end of life are not physically or mentally able to make decisions about their medical care, including 70% of older adults who require treatment decisions, up to 69% of nursing home residents, and approximately 40% of adult medical inpatients. So COVID-19, that epidemic has also brought advanced care planning into focus. Patients who had not previously thought about advanced care planning are seeing the effects of this terrible disease, and they want to make sure their decisions are followed if they end up contracting it and having significant disease progression. Additionally, with the move to value-based medicine being led by CMS, providers are going to be incentivized to create advanced care plans for their patient populations. Second. So there are several different kinds of advanced care planning documents, right? So within those categories, the documents themselves often vary by state, with some of the states mandating specific forms, while others are more flexible in the formats they accept as legal. The proxy, or the medical power of attorney, document allows the patients to select someone else to speak on their behalf if they are unable to speak for themselves. This is a legally binding document that varies from state to state, with some states requiring witnesses while others require notarization. The living will document allows the patient to specify end-of-life treatment options should they become necessary. And so that's going to include decisions like artificial respiration, nutrition and hydration, surgery, blood transfusions, and more. Living will documents typically cover end-of-life scenarios such as terminal conditions, persistent vegetative states, and end-stage conditions. So this is something that's typically used in the ICU environment. In many states, the proxy and the living will documents are combined together into a single document. In others, they're two separate documents. The do not resuscitate document allows the patient to indicate that they don't want heroic measures to be taken if they die, such as automated external defibrillation or CPR. And so you see this more in the emergency setting. You have the physician order for life-sustaining treatment. So this goes by a lot of different names depending on what state you're in. And so those are actually created by providers, and they indicate specific treatments to be provided or withheld based on an existing serious illness or general frailty. And there's some other documents that are becoming more common as well. So you've got the Advanced Directive for Dementia, for example, which allows patients to specify treatment options when they are physically well but suffering from mental decline. There are also some organizations that support particular patient populations. COPD would be a good example of that, some of the cancer organizations. And they often also provide some documents that supplement advanced directives, and they provide guidance on their specific disorders. So the options for representing advanced care planning document in FHIR are currently a little bit limited. So one of the only ways that you can do it in the 4.0.1 release is to attach a PDF of the document as a document resource linked with the patient. So really, you don't have many details about the information. It's just stored in the PDF and chucked in the document bucket. So the consent resource team was originally working on folding in advanced care planning as part of what they were doing. So they had the data consent that they had already built out, and advanced care planning was one of the other things that they were looking at. But in their research, they concluded it was just a little bit too complex to include. So what they've done is they've handed off the effort to the patient empowerment team. And so they're now looking at the problem with fresh eyes. So that makes this a great time to talk about how we can store advanced care planning documents in FHIR and what the best way to do that might be. So PDFs really serve two roles So basically, PDFs are really serving two roles in the work environment. So PDFs aren't a great way to store accessible information, and advanced care plans aren't very good at that. Each state has its own recommended format. Each state some states can combine proxy and living will into a single document. And so basically what's happening is, the document is doing two things. It's providing legal support. So for example, if an angry son or daughter tries to sue when treatment is withheld, there's a document that shows the decisions made by the patient prior to becoming incapacitated, right? So the proxy that they selected, any treatments they choose to receive or not receive. But the main function of them is to provide information to the providers and the proxies so they can understand the decisions patients have made for their end-of-life care and make the right decisions on the patient's behalf. So PDFs are great at the legal protection part, but they're terrible at informing the decision process. So what we can do is we can make advanced care plans a little more useful by capturing some metadata when the plans are created. Right. So the idea is that some of the information associated with the plan is pulled out and used to annotate the document, and then also would be provided via FHIR calls when the advanced care plan is received via FHIR. Right. So this is similar to what the consent team was already working on. They had built some of this out for data sharing consents. So this similar concept to that. So the kinds of information we might want to capture would include things like the originator of the advanced care plan, which is usually the patient, but in the case of PULSE documents would be the provider. The subject of the plan, who's almost always the patient, the type of document that's being represented, and also some assertions about the document's content. And this is where the meat of it is. So the assertions would vary significantly, but might include the questions like who are the primary and secondary proxy or medical power of attorney that were selected by the patient? What treatments are prescribed and proscribed in a PULSE? And what treatment preferences are indicated in DNR and living will documents. So using metadata to annotate the PDF document also allows us to capture some nuance that might not be found in the document itself, right? So these documents are usually about the what, right? So I want nutrition and hydration. I don't want respiration or CPR support. If I'm in a persistent vegetative state, I don't want any treatment, those kinds of things, but they're not about the why. And unfortunately, the answers to the why questions are a lot more useful to providers and proxies if they're trying to make decisions at the end of life. So for example, metadata can collect information about a patient's goals and values. So for example, I want to die at home. I don't want to be kept on life-sustaining treatments if I can't move or speak, those kinds of things. As a patient's end-of-life condition changes, these kinds of statements can guide proxies and providers to make the changes in care that are appropriate. Metadata also helps all the participants in the patient's care. This isn't just about helping patients, this is about everyone. So bringing out the end-of-life choices into metadata makes it more likely that patients will only receive the care they want, right? Because providers and proxies can identify that information more easily than if it's embedded in the PDF. It also, as we talked about a little bit earlier, helps inform the decisions made by the providers and proxies at the end of life. But this metadata is also potentially good for payers because it can help keep costs down by making it more likely that the treatment that is not desired isn't going to be provided. Capturing the metadata also opens up opportunities for emergent behaviors and innovation, and this is where it gets really interesting. PDFs, especially those that vary as widely as advanced care plans, and I mean, every document is different, it's insane. They're very difficult to decompose into data points. So if you can bring that data out into the metadata and attach it to the document, that allows algorithmic behaviors to be used to process them. Right now, they're machine readable and machine usable, as much more so than a PDF would be. So for example, payers might use anonymized data of their patient base to do risk analysis and stratification, as well as forward cost planning. Providers will now have a better picture of exactly what advanced care planning has and hasn't been done for their cohort. And they can provide new detailed reporting in the world of value-based medicine, which I think is going to become more prevalent as we move forward. And then additionally, exposing some of the details of the advanced care planning as metadata will allow innovators to build new applications that can provide a more user-friendly picture of a patient's overall advanced care plan to providers and proxies. So, right, so you can see this information in a nice interface rather than having to dig through a document. There are some challenges to this approach, of course. If the original advanced care planning source is a PDF, so like you've got an advanced care plan that's created outside of the medical context with an attorney, for example, then the PDF is going to need to be indexed before it reaches the system of records so that the metadata will be available, right? If a standardized form is being used, and 5 wishes is a good example of this, you might be able to extract some of that metadata automatically because the PDF is going to be standardized and you should be able to reach in there and pull out the information you need. Alternatively, there are some tools out there that are used to create advanced care plans by asking questions. And a lot of times those tools are gathering the metadata as they go. And when they generate the actual final document, which is then made legal, you can also gather that data as well and associate it as metadata when the form gets uploaded to whatever its final destination is. So with the recent challenges in healthcare and the change in stewardship of advanced care plans in the FHIR working group hierarchy, I think we really have a unique opportunity to model these plans in a way that will benefit all the participants in the patient's end-of-life care. While it may require additional effort to capture these metadata, annotating the advanced directive with that metadata will greatly enhance the directive's value to the patient care. Incorporating metadata into the approach will benefit proxies, providers, and payers, and most of all, it'll result in patients being more likely to receive the end-of-life care they want. Thanks, I'd be happy to take your questions.
Thank you, Kevin, so much for that overview. We have received a couple of good questions. We'll start with the first one that came through. Kevin, what inspired you to focus on this patient population?
Well, it's interesting. I have a client that I've been working with that is focused on advanced directives, and they wanted to be able to pass them around with FHIR. So I immediately sort of discovered looking at FHIR that there wasn't a great way to do that yet. It's also something that's important to me. I've had a couple of relatives that have passed away from COVID. So it's become something that's very much in the forefront of my thoughts. And I reached out I was connected actually by Cambia with David Pike, who was running the consent resource over at FHIR. And he explained to me that while they had originally intended to put it in there, they couldn't because it was just a little bit too much for them to wrestle with the ground. So, once I learned that there was an opportunity to step in there, I thought, I have some data design experience. Maybe I can bring some of the experience that I've had with advanced care planning to bear on it to make sure that what we design going forward is something that's more useful than just a document in a bucket.
Great. Yeah, thank you. Another question came through. What is the biggest barrier moving this work forward? Is it tech related or cultural?
Well, I think it's a little bit of both. You know, advanced directives are sort of kind of a weird beast because they're not part of the normal course of care. You know, value-based medicine is moving things towards a point where advanced directives are now going to be part of the quality metrics. So there will be inherent financial value to the doctors to manage that. But I think realistically, the barriers are not technical; they are cultural. They are, you know, getting a doctor practice to shift to do anything is pretty difficult. But I think that especially if COVID is here to stay, and it certainly seems like it is, at least in the short term, that there's a case to be made that this is something that's going to benefit everyone and should be pursued.
Absolutely. Yep, I agree. Okay, we've got a couple more questions coming through, and we do have a few minutes to take them. So the next question reads, as a physician, if I am standing in front of a patient, the items I need to know is if they have a POA, advanced directive, etc. We find it hard to find out if they have these items. Is there an API that would allow a provider to know if this exists?
Well, so it depends on your EMR. I mean, so if you're using an EMR that is capturing those, then, for example, I know Cerner just did a deal with a company called Vinca to provide a registry for advanced care plans. They're still only in document form, but they are there. But, you know, a lot of times it'll be, well, I've got it in my safe deposit box and I made it 30 years ago and I haven't touched it since then. So I think the challenge is not only to identify, does an advanced care plan exist, but to really make sure that you have a copy of it and you know what's contained in it. You know, and in our experience, the most important thing is who's that medical proxy? Who's going to make the calls if you're incapacitated for some reason? And from a legal protection perspective, obviously the doctor's going to want to know, do I have the document to back that up so that I don't end up getting sued by another family member who wasn't involved in that process? So there are some technical ways that that's becoming easier. There are registries that are going up that are quite common. There are various private companies that are designing advanced care plan solutions that will act both as a way to create those documents and to provide them as an application across the web, so you'll be able to access them that way. So I think relying on the EMR or on general registries is not going to be a great source of truth. We may end up having to do some sort of a federated model to where we can pull various sources of truth together and sort of canvas them all and say, okay, for this person, does this plan exist or not?
That's great. Thank you so much, Kevin. Okay, I think we are about ready to move on to the next presentation. So Kevin, I would just like to say thank you so much for sharing that summary of such an important topic with our community. And thank you for your hard work.
And thank you.
Okay, I would like to now invite the next topic to the stage, diving into social determinants of health. Would Joe, Fawn, Jen, and Mark please join me on stage? And Joe, I believe you will be sharing your screen and the slides. So once again, just do a quick round of introductions and then take it away.
All right. Hello, my name is Joe Kliegman, and we'll be presenting today about moving towards standardization of social determinants of health. This was an extraordinarily strong group that brought together depth and breadth in our multi-pronged effort to tangibly advance interoperability for social determinants of health. I'm joined by Jen Garcia, who's a registered nurse at Seattle Children's and has a master's in clinical informatics. Dr. Fung Matthews, who's a pharmacy doctor who's completing a master's degree in biomedical informatics, and Mark Francis, who has a master's in public policy and is the digital health integration officer for Electronic Caregiver. I want to start by by defining social determinants of health. According to the WHO, social determinants of health are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And what's interesting about social determinants and why they're so important is that social determinants are so important because research tells us that they account for 80% of a person's health status. To appropriately treat patient health, identify gaps in care, and measure health equity, we really need to document and be able to communicate about these critical health risks. So I want to ground this work with a patient story that will hopefully help illustrate the critical need for this work. And I'm going to do that with an individual named Travis. Travis is a 52-year-old man who landed in the ER. After admission, we learn that this is his third ER visit in the last 3 months and has a documented diagnosis of type 1 diabetes. After an extended conversation, we learned that he has been homeless and experiencing financial stress for 2 years and has never filled his prescription for his diabetes medication. I guess this story is meant to illustrate the broken cycle of effective care coordination between patients, healthcare networks, and community-based organizations that provide social services to individuals. Travis was repeatedly admitted and discharged without receiving the care that he needed because tools used to document and coordinate care were not up to the task of prioritizing financial stress as the underlying condition that really prevented him from getting the appropriate diabetes treatment that he so desperately needed. So the fundamental problem is that we all wanted to work towards addressing is that patients experience poor health outcomes because providers aren't able to appropriately coordinate care. And there is strong evidence that standards for social determinants of health in particular will help improve care coordination so that patients like Travis can receive the care that they need. For those familiar, this work is fundamental to advancing the Quadruple Aim. The Quadruple Aim is, the uncontroversial aspiration that's supported by, Health and Human Services and kind of a number of, policy governing bodies. And it's kind of the charge and desire to improve patient experience, improve the health of populations, reduce healthcare cost, and improve care team well-being. And together, these elements constitute the Quadruple Aim. And we think that addressing standards for social determinants will actually do a lot toward improving every single one of these components. So in terms of the work that each of us actually did, so we work closely with the Gravity Project. And the Gravity Project is an organization that was created specifically to address the lack of SDOH standards in healthcare. Gravity is a convener of stakeholders across the healthcare continuum that has shouldered a significant part of the task and burden of developing social determinants of health standards. So working with the Gravity Project and other stakeholders, each member of our group worked to tangibly advance standardization and use of social determinants of health in healthcare by working on 4 different elements, and those elements were terminology, FHIR implementation, policy, and identifying and reducing barriers for community-based organizations. So, and each one of us kind of took one of those as our task. I was the policy designee. Mark was the FHIR implementation designee. Jen was in took the community-based organization part of it, and Feng took the terminology component of it. And so at this point, I'm going to hand it over to Feng, or Dr. Matthews, and she's going to tell you about the terminology project.
Great, thanks, Joe.
Oh, sorry, there one more slide, but then she's going to talk to you about the terminology.
This is great.
Take it away.
So when we look at patient care, health information is consistently being entered into the EHR. The same can be said for capturing the social risk within the social determinants of health. But however, as you can see, the issue becomes the information captured is not being standardized. So the meaning and use of these social determinants of health and social risk are not consistent and does not reflect any similar concept and can further complicate the information exchange. And so to bring those into a standardized format, we find the three components, as Joe had mentioned, terminology, fire interoperability, and policy, to bring them together. And then when we bring in the community-based organization to the conversation, collectively, these elements will impact the standardization of social determinants of health and not only improve patient care, but overall value-based care. Next slide, please. And so within patient care, there are going to be multiple stakeholders that may need to communicate with each other. And so this is not an inclusive side, but just to show that potentially you will have payers that would need to talk to home health, patients trying to reach out to their providers, hospital admins, and even policymakers in the mix. So ultimately, these interactions between entities are inevitable. But what our goal is to move the conversation to the right side, where standards become a tool for the communications between entities. So whenever there's an exchange of information, the same universal meaning is being used and then minimizes ambiguity. Next slide, please. So I'd just like to go a high-level overview of the consensus process within the Gravity project. I believe this is important to indicate the level of the work applied and the depth that these processes take and the time that is embedded into developing and standardized terminology. And this is the part that I was mostly involved with Sarah DeSilvi and the team at the Gravity project. So the first thing we do is the quick review of the current terminology that's available within the organization, such as ICD-10, CM, LOINC, SNOMED CT. And from there, we pulled any code that is available that is capturing the social risk, if there are any. Next, we move on to the literature search. We want to look and see how these domains are being defined, portrayed, and represented within the research literature. And once we combine all of these findings, we move over to our SME review. We have subject matter experts within each domain that will review the content and have an adjudication process. So all of these moves towards the development of the standards, where we could find further definitions within the domains and propose terminologies that captures the right concept that we want. From there, it is sent over to a voting process within the community so that we get that consensus. Next slide, please. And so quickly, I'd just like to show you an example of the transportation insecurity that I was part of. This is how it's being represented within the literature. As you can see, there are multiple terms used. It can be referred to as transportation barriers, transportation needs, disadvantage, and so forth. And so if we think back of Travis's story, would any of these pertain to his situation? Is there a way that we would be able to find out his social risk within the first visit rather than the third visit? The fact that he had no home, no financial means, and then no ability to afford his medication. Next slide, please. And so to capture these social risks, the most common methods is the screening questionnaires. There are multiple screening questionnaires being used in the healthcare system currently. Some are validated and some are not, and some are also incorporated within the EHR. And if we follow our transportation insecurity example, these are the questions that you may find in some of the questionnaire. It's typically one question that is being referred to transportation. What I really want you to look at is not just the question itself, but the binary answers that it provides. The patient can only select a yes or no answer. And so that provides little to no information of what the transportation insecurity might be with it. And so if we look on the other side, potentially the patient, yes, I missed my appointment today, or I missed my appointment last month because I didn't have the money for the bus. And so the availability of the transportation means it's there, but potentially we miscaptured the financial strain that the patient may have. And so this is ultimately what the Gravity project is really working on the terminology side, is bringing that standardization to the screening questionnaires and the screening answers, but also the diagnosis, goals, and interventions, and capturing really what is the main concept that we want to be able to use to improve patient care overall. But the standardized terminology is really only one part of this multifaceted solution. The next come interoperability, and I'll let Mark speak on that.
Thanks, Fung. Next slide, please. Thanks. Yeah, so this is where FHIR comes into play. So FHIR is a standards framework that defines how electronic health information can be exchanged. FHIR builds upon previous versions of HL7 while incorporating the latest web service protocol standards and technologies. FHIR is being adopted with 87% of hospitals and 57% of clinicians using FHIR. Next slide, please. To achieve impactful outcomes, I hope that you'll see that there's an acknowledgement that electronic health records should include social determinants of health. As noted, we worked with the Gravity Project, a group that's developing standard terminology, ICD-10 codes, and implementation guides that capture SDOH data in a consistent manner for inclusion in EHRs and APIs to facilitate data exchange. The initial focus is with clinical payers and providers and traditional EHR vendors. The future focus will include community-based organizations. Next slide, please. Today, many EHRs and clinical assessment tools do capture information associated with social determinants. However, there is a lack of consistency. Most SDOH data elements are custom to the specific EHR implementation, so the data cannot be freely shared. The Gravity Project and others are working to address this need for standardization. Meanwhile, as is often the case, the market is responding. Related to patient transportation, over the last year, Lyft is integrated with Epic and Uber has integrated with Cerner. So the two major EHR vendors are starting to bring in social determinants in a very impactful way. Now let's go back to our story of Travis. Travis was fortunate because he was seen by providers that include social determinant data. As a result, upon discharge, Travis is seamlessly connected with housing, transportation, and social services. This leads to better care and better outcomes. Now, over to Joe.
All right, thank you, Mark. So my piece in this was the policy piece. So the goal was to influence the creation of regulatory standards for interoperable exchange of SDOH data. So the Office of the National Coordinator, or the ONC, is the chief federal regulatory agency under Health and Human Services that dictates national standards for health technology and the electronic health record. The ONC maintains the US core data for interoperability, the US CDI, which is the set of health data classes and data elements that are required to be interoperable by all health information systems nationwide. We engaged with a sub-regulatory process to make to recommend inclusion of social determinants of health data for consideration in an upcoming rulemaking process. So, you know, the steps for this sub-regulatory process were to submit new data elements and classes. ONC evaluates and assigns a level of maturity to each data element. ONC post-submitted data elements on USCDI by level, and then there's a public comment period for the rulemaking process. So there were two components of this. The first component was a letter. We wrote a letter to the Honorable Donald Rucker, who's the head of ONC, to advocate for the inclusion of a new social determinants of health data class in the US CDI and to articulate the granular structure of data elements within that data class. And then the second activity as part of this effort was to develop a structured submission to the ONC that offered kind of a more detailed technical granular description of the data elements within the proposed data class, as well as a presentation of the maturity of data elements and evidence of their current use and exchange between healthcare providers. But both of these, so what I'm showing on screen is the US CDI version 1, which, as you can see is relatively sparse, and I'm illustrating a new SDOH data class along with different data domains speaking to different types of social determinants. So both of these recommendations were submitted to ONC to be included in their upcoming rulemaking process. And going back to Travis, we can think about current state, where if Travis goes to one healthcare provider, maybe they have these elements, maybe they don't, and he tries to go to another healthcare provider, and there's a different regime or a different set of custom elements that where they aren't able to appropriately treat his condition or see his medical history from a prior visit. So I'm going to hand it off to Jen Garcia, and she's going to tell you about the community-based care part of the project.
Thanks, Joe. So HL7's FHIR standards may be the key to interoperability between healthcare organizations and social service community-based organizations like food banks or housing shelters or transportation resources. I'll call them CBOs from here on out, but it still comes with several challenges. For my part of the project, I interviewed stakeholders within the industries of healthcare, social services, and EHR interoperability to identify the obstacles for interoperability using FHIR if the provider is the community. Next slide, please. So using Travis's story, the hospital's case manager is up against several challenges without SDOH standards and FHIR interoperability when trying to place Travis using a referral to find housing and transportation. I'll start reviewing these challenges in the slide from top down and then left to right. So the lack of standards and guidance for information in a working referral affects both the healthcare provider and the CBO. Lack of standards brings up questions like, what pieces of information in the hospital chart are helpful to a social services person and vice versa? Also, without a standard working referral, how can one track if a referral was successful if made outside of a healthcare organization? There's no mechanism that exchanges or confirms the referral submission outcome to ensure continuity of care. Another common obstacle was that the software that CBOs use often lack FHIR capability. Several interviewees noted lack of funding for investment into a vendor with FHIR capability, and also current national, state, or local level regulations don't provide incentives for CBOs to invest in FHIR technology. Next, we learned in FHIR Fundamentals class as Cambia Grove Fellows that the resource care plan is a shareable FHIR resource component in the electronic health records. However, how CBOs and healthcare organizations use the care plan differ greatly. Care plans in the hospital setting focus on single encounters spanning short time periods, such as a day or a 1-week stay or a 1-month hospital stay. Food security or housing care plans use a longitudinal focus, like spanning years, and do not use the same language when describing a patient's needs. So with these differing perspectives of care, how would one measure success or failed care gaps of a patient like Travis moving between healthcare services and social services over time? Travis needed both housing and transportation. Determining eligibility can be difficult due to lack of shared language to describe the patient's needs. Applying for coverage using limited ICD-10 or LOINC codes without SDOH elements may not accurately reflect Travis's social and health status to be able to find resources to support him. Lastly, there's also a privacy and security as well as appropriateness issue of sharing information between a CBO and a healthcare organization. How much access to a patient's chart should a CBO service providing a resource have, and for how long? Looping back to lack of standards, without defined FHIR information sharing standards and guidance, this is a considerable gray area that is a potential risk for patient privacy and information security. Next slide, please. So currently, these are the solutions in the works for SDOH for FHIR interoperability for data exchange and EHRs. For defining terminology, Gravity Project is working on defining SDOH terminology. As for defining protocols, we've heard in previously mentioned group projects today about other organizations that are looking into EHR interoperability. I know of one, the National Interoperability Coalition, Project Unify, is working on demonstrating EHR interoperability using open source means. However, these solutions do not address all the challenges I previously mentioned. There's some models of progress, like 211 San Diego. They've successfully shared patient information within their exchange network. These interviews validated that there's still a lot of work to be done to address EHR interoperability and data exchange, then extending that to social service CBOs to effectively coordinate holistic care. Next slide, please. So we recognize that there's a huge need for investment and incentives in FHIR interoperability, specifically for community-based organizations. One interviewee had an interesting take on health data technology and the principles of harm reduction. The innovations of technology in healthcare have benefited society, but have also caused harm. Harm by algorithmic regulation and opaque mechanical decision-making. As stakeholders, we should consider what is our goal with healthcare interoperability and what is the safest possible way we could do it. Noting the Gravity Project's principles for equitable health and social care, a future consideration could be the creation of a data governance committee to determine guidance for safe practices for SDOH use to protect patients, their health and social data, and our communities. Next slide, please. So back to Travis. Had SDOH standards with FHIR interoperability been in place at an earlier time for Travis, discovering his social needs for housing and transportation during his initial ER visit would have been crucial in optimizing his diabetes management, his overall patient experience, minimizing missed opportunities, as well as decreasing healthcare costs. Last slide, please. So this concludes our presentation. On behalf of our group, I'd like to take this time to acknowledge the following. Special thanks to Cambia Grove for this fellowship opportunity for FHIR interoperability. Special thanks to the Gravity Project PMO team, Sarah, Evelyn, Bob, Mark, Linda, for the chance to be part of this important work aiming to improve social risk for patient care. And thank you to our CBOs and subject matter experts for guidance and insight to the many challenges of FHIR interoperability and SDOH standardization. Thank you all for your time today.
Thank you all so much for this incredibly important overview and for diving into this topic. We have time for only one question, unfortunately, and it's a big one. So I'll read it as it was written. Incredible work. How can this work lower some of the cultural barriers preventing improvement of social determinants of health? One of the biggest barriers in the political and policy space has to do with this notion that people must want to help themselves before a larger system or governmental solution can take hold. How might your work navigate this short-sighted perspective?
I'm happy to give my idea, and everybody else can jump in. Yeah, I think that's a great question. I think an important point is that inclusion of social determinant standards could really do a lot towards reducing healthcare costs. And if there was a kind of a cultural barrier, focused on like your own individualistic or needs related to not wanting have to pay or shoulder a burden for someone else's care. I think this work is important because ultimately it will drive down costs. At the end of the day, if a patient goes into the ER without an ability to pay, that cost associated with that visit is shouldered by the rest of society, whether we want to or not. And so having a structured way to really deal with and address these social needs head on will be good for your own self-interest, in addition to having a benefit for the rest of society.
Well said, and in the perfect amount of time. Thank you all again for diving into this really important topic. We know that our community has such an appetite for this specific realm of innovation. So thank you for sharing your learnings with us here today. Okay, it's time for us to move on to our next presentation. I would like to call Tyrone to the stage, please. Dr. Grandison, if you could join me.
Hi, Julie.
Hello, welcome. Go ahead and pull up your presentation. Share a quick overview of just an introduction of yourself, and then go ahead and take it away.
Perfect, thank you. So I'm Tyrone Grandison, the Chief Technology Officer for Pearl Long-Term Care Solutions. And today I'm going to talk about the silver tsunami. And just to level set everybody, it is the metaphor that talks about the increase in the senior population over the next couple of decades. Today, around 17% of Americans are 65 and older. There are probably around 15 million Americans in this category, with approximately 10,000 people turning 65 each day. And by 2030, every baby boomer will be age 65 or older. This means that 1 in 5 US citizens will be of retirement age. And globally, this segment is actually the largest growing age dynamic and the largest growing consumer group. The shift is happening everywhere and no country is immune to it. It's the logical conclusion of life expectancy actually increasing and birth rates declining. So between 2015 and 2050, the world's population over 60 is going to double from 12% to 22%. Not only that, but currently the number of people that are age 60 and older outnumbers children younger than 5. Even more interesting is that the pace of population aging is much faster than in the past. As a planet, the speed of aging is accelerating across every single country. Now, in America, the current development paradigm for at least the last 7 decades has been that we should focus on meeting the needs of families with kids. This has meant, society that has city planning focused on single-family homes, on automobiles, on commuting, on infrastructure around the suburbs. What we're seeing over the last decades and with the current demographic trends is that America now has to shift to a new paradigm, one that is focused on seniors. And this will impact all systems. The policy world and the justice system will have to evolve to address elder abuse and elder care. Housing and transportation must adjust to support communities of seniors, and healthcare must adjust as well in multiple different ways. Right now, the share of healthcare spending that comes from people over 65 and above is close to around 40%. And we expect that to increase to near 50% by, say, 2025. This means that we're going to have an explosion right now from healthcare spending being $4 billion to be around 5 to 6 billion. And it's going to take up a huge proportion of GDP. What's even more interesting is that there's going to be obviously an increased demand on the healthcare system in a number of ways, but the fact that it's going to be out of reach for most seniors. It is out of reach currently, and it's going to get worse over time. The even sadder portion, and I hate to be painting this really sad picture, is that the current system is not equipped to handle the tsunami that's coming. It's stressed, its functioning is inadequate, it has problems in terms of cost, financing, access, and quality. Before the pandemic, demand already exceeded supply. There was a lack of standards and adoption. Within long-term care facilities, there was a shortage of staff. Occupancy was around 90%, despite a huge demand that could not be filled. The maturity in each of these facilities was low, defaulting on manual processes whenever possible to get the job done. A plethora of technology solutions in each facility. The maturity of both the systems and the people was not very high. And the time it takes to actually get somebody from I want to actually get into a long-term care facility to getting them there takes several months. Now, when you drill down and you look at long-term care technology and data, two things jump out at you. The first is that there's minimal national standards and there's no uniformity in the language that the industry speaks. Currently, there are two solution initiatives that are addressing this problem. There is the Electronic Long-Term Services Supports Initiative, ELTSS, partnership between the Centers for Medicare and Medicaid, CMS, and between the Office of the National Coordinator for Healthcare Information Technology, ONC. And then there is the Paseo project, which is, again, sponsored by CMS and being led by the MITRE Corporation. ELTSS focuses on two use cases. The first is around eligibility determination, around plan creation and approval. And the second is around how do you actually share that plan. Whereas the Paseo project is focused on care coordination, more specifically post-acute care coordination. Now, both projects are complementary, and in a recent Connectathon successfully demonstrated how they can be leveraged together. Now, the mission or the task of this particular project, the LTCCAT project, in this vast ecosystem of problems in the long-term care space, is how do we actually find a really targeted, focused, and simple-ish problem that we can actually chew on? And that was, how do we speed up the intake and the onboarding for a senior that's entering a care home, whether they're looking for short-term or long-term care? Our long-term goal for this project is to create a FHIR resource specification along with associated enabling technologies for a senior that has found a home and is in the process of actually securing it. Our intention is to enable the seamless exchange of data between the senior and the long-term care facility, removing the current pains and burdens that both are experiencing. Now, our process involved working with 19 long-term care facilities across independent living, assisted living, skilled nursing, and memory care to come up with a common set of data items that they need for applicants to successfully go through the process. Then we created a database schema for this set and then cross-reference it with FHIR resources and CMS's data element library. We incorporated lessons from the ELTSS initiative and from the Paseo project, and use the IGPOP and FHIR-based tools from Health Samurai. And what that enabled us to do was to create a draft FHIR resource spec, what we call LTC facility application. It also led us to think of interesting ways in which LTC providers can actually ingest data for a long-term care application. One way that we actually tested and settled on was using FHIR-based to provide or provider partners with a way to read exported data. So data that was exported from Pearl into their own systems. And this was a trial with 2 of our partner providers. work in progress is on converting Perl data, which is in MongoDB and MySQL, into this LTC facility application via what we're calling a translator, which is just an interpreter written in Python. And all the mature assets for this project are open source and accessible on GitHub at this point. For those who are interested, here's the structure of the draft Fire spec. And this is the current state. It should be noted that we have a current state and a goal state. In the goal or the ideal state, we included the cognitive status, the functional status, and the advanced directives fire resources from the Facade project, and some underlying resources that would capture some nuances that are currently not being addressed by Fire. But in this exact current state spec, we only actually use existing resources. So our ask, we have 3 of them. So given that there are over 15,000 long-term care facilities in the US, and our initial cohort of 19 is probably not going to be inclusive and diverse, our first ask is basically like, help us figure out like what data items should be included in the spec over time. The second ask is, based upon a hunch. So we guessed that since there are a lot of systems being used in any particular facility, some of these systems may not have fire capabilities. And we want to either prove or disprove this conjecture. So we want to work with people to figure out like what they're using and what capabilities they have. And finally, we want to put a call out to any IT vendor that wants to work with us in creating translators from this draft fire resource spec into their systems that they're providing to LTC facilities. With that, I'm going to thank Cambia Grove and thank Health Samurai and all the partners that we worked with. If you want to reach out, please email me at ty@perlltc.com, and I can be reached on LinkedIn. Thank you so much.
Thank you, Dr. Grandison, for your overview and for your work here. A question that we received in advance was around if you were to make a request to the innovation community at large about the best way to mobilize to prepare for the silver tsunami, what advice would you give?
Oh, that's a very good question. I'd actually say, look at all the systems that you're building through an aging lens, aging equity lens, so to speak, and make sure that the solutions that you're building are focused on that paradigm. So would the solution you're building be useful or have the constraints of somebody who may have issues with their eyes, may have mobility issues, may have issues with navigating a keyboard, may have issues with reading the text that you're providing, may not have their main modality or way of interaction being a phone, right? So having that eye or that mindset while you're developing and while you're building, that is really, really important.
Great advice. Wonderful. Okay. We are about out of time, unfortunately, Dr. Grandison, but thank you so much for your overview and for all of your hard work. Okay, with that, I would like to call our final presentation to the stage today. It's another discussion about the Patient Access API. This one is the current state of consent and opportunities for innovation. We will call Mike, Fawn, Doan, Daya, and Aju. If you could please each turn on your videos and unmute yourselves. And again, as a final reminder to the audience, please do share your questions in the Q&A box, and we will get through as many of them as we have time to towards the end of this presentation. And if you guys wouldn't mind doing one more round of introductions for folks that have joined us a little bit later in the event today, that would be great before getting started. Take it away.
Hi, I'm Michael Berby. I'm Enterprise Data Architect with the Washington State Healthcare Authority.
I am Fawn Matthews. I'm a pharmacist, and I'm currently with Point of Care Partners learning on Fire and DaVinci ID.
I'm Aju Jacob. I'm an enterprise architect, currently leading the interop activities at Blue Cross Blue Shield of Tennessee.
Hi, I'm Daya Sharma, the CTO of the Handoff Company.
Doan Ham, I'm the Performance Improvement Director at Cedar Hills Hospital.
Great. So just real high level, our agenda. I want to talk about background and current state when it comes to the patient access API, and specifically in this project, we focused on consent. And we want to talk to you about what the goal of our project was, our approach to the work, our findings, some of the challenges that we discovered, and then also the many opportunities there are for innovation around consent and specifically granular consent. And then finally, where do we go from here? So I'm just going to touch briefly on the background since you've already heard it from the other project, but obviously the CMS Patient Access API requires payers to expose the healthcare data that they hold for their members via FHIR-based APIs. In terms of consent, that is really handled through implementation of the Smart on FHIR implementation guide, which builds off the OAuth 2.0 and OpenID Connect protocols and standards. In terms of payers' processes to ensure the APIs are accessing patients' data appropriately, there are really four steps that payers can take. And that's the app registration process, the authorization process, an optional attestation process, and then an providing education materials to their members and patients. So those are really the four buckets, and we'll dive deeper into those later. But really, again, emphasizing CMS's push for the rule is to liberate patient data overall. And it turns out that most people agree with that. There was a Pew survey conducted July of this year after the rule dropped, in which 61% of the 1,200 or so adults that were surveyed said that they would like better access and more access to their healthcare information to better manage their health. So in terms of the third-party apps, some of the experts that we talked to see them as a potential future driver for interoperability. The apps can provide more holistic view of healthcare information to patients, depending on how apps actually present the data, and that will be one of the significant challenges that most of them face. But we want to acknowledge there are both privacy and security concerns that have been voiced around the access of the data by these applications. So in terms of the regulatory protections for the data when it relates to the Patient Access API rule, once the data leaves the possession of the payer, who of course is a covered entity under HIPAA, the data is no longer protected by HIPAA. Now that's not to say the data is still not protected, but it's not protected by HIPAA. It is protected under regulations maintained by the Federal Trade Commission, the FTC. So to touch on that, that same Pew study that was conducted in July, 56% of the respondents, when asked about exposing their healthcare information to a third-party app, said they would not be comfortable unless there was some sort of pre-approval or oversight body that took a look at the app and made sure that it was approved for use. So that was really the focus of our project and why we wanted to dig into this. So I'm going to pass it over to Fawn now to talk about the current state consent with the API rule.
Great, thank you. So as Mike mentions, the patients have shown concern on the security and privacy of their information. And so the first question that might come to mind is, well, did I give that approval or was consent given? And so when we think of consent, there's two terms that describe the need for it, the protection and the privacy. We usually think of protections in terms of being critical in protecting against unauthorized, inappropriate use of patient data, and privacy being crucial in the notion that the individual can freely choose how much information can be exposed or shared. And so when we look at interoperability coming into play, especially for third-party apps, we find that the CMS rules require payers to implement the Smart Application Implementation Guide, and that the ONC 21st Century Cure Act supports the use of Smart on FHIR core capabilities. And this is all due because of the well-vetted FHIR profiles we have available. Next slide, please. And so if we look at what it takes for payers' requirements or what they should implement to allow patient health to be accessed by a third-party app, we see that there are about 4 processes: registration, authorization, attestation, and education. And so we'll briefly go over some of these. Next slide, please. Again, the first step for this is the registration. For a third-party app to register with a payer, the app should use the OAuth 2.0 Dynamic Client Registration Protocol or a manual pre-registration portal. After the registration process is complete, the authorization process is next. For the third-party app to access the patient health data that a payer holds, it must use the OpenID Connect protocol, and this includes the exchange of ID, security tokens, access tokens, etc. Now, once the app is registered and authorized by the end user, or in this case, the patient, the app is then able to access all health data as listed by the CMS rule, such as claims and clinical data. This essentially is the entire consent process. Yes, you can see all of my information, or no, you cannot, and I do not authorize the app to be used. Then I'll pass it over to Aju.
Thank you, Feng. So a very common question from payers on the topic of onboarding third-party applications is, what's the extent to which they can vet a third-party application before granting access to the FHIR APIs? Unfortunately, the answer to that question is not a whole lot. And the reason is CMS's sentiment is to give patients the right to pick applications of their choosing and not really the applications of a payer's choosing as it used to be in the past. So it actually aligns with their motto of liberating patient data. So that being the case, payers still have a couple of options available to them to guide and inform their valued members. So one of them is actually an application attestation process. So payers can actually require application developers to complete an attestation before they allow this application access to the FHIR APIs. But one thing to keep in mind, though, is actually you cannot deny access based on how someone responded to this attestation, or even if someone chose not to respond to that attestation, you still have to grant access. But what you can do is actually share this information with your patient so that they can use their judgment before they start using this application. A second option is to direct your patients to the Care in Alliance's myhealthapplication.com website. And this website has a list of several health applications, third-party health applications out there. And Karen also tags the applications that have attested to their code of conduct with a symbol right next to the name of the application. That's what you'll see on the slide, the blue symbol, the tag. So this is another tool that payers can actually share with their members to help them better. Next slide, please. Payers can also publish their own patient-facing education materials. In fact, this is actually a requirement from CMS. So payers can actually use that to their advantage. So to help and educate their members on the various nuances around the patient access API. And talking about nuances, one example of such a nuance is, once the data leaves the possession of the payer, it is no longer protected by HIPAA because third-party applications are not covered entities. So what payers can do is include this kind of information in the education materials, and maybe even include the links to the Care in application list to help their members on this new, help and guide their members on this new capability. Next slide, please, and I'll turn it over to Dawn.
Sorry. The overall goal of our project was to focus on patient consent in sharing their healthcare data with the third-party apps. Our intent was not at all to question if the rule goes far enough for consent, as it drives players to use a highly effective security and authentication protocol. We just see this as a potential opportunity to allow the patient to have more granular control of consent when it comes to sharing the data to the third party. So our goals include in highlighting some of the changes that exist around granular control consent, highlighting some of the solutions that other industries such as finance has been handling with their clients' data sharing, and acknowledging some of the current initiatives and work related to FHIR-based consent. Next slide, please. In order to achieve our goal, we implemented 4 different methods. First, we conducted interviews with various experts in consent, FHIR, and interoperability. We also conducted a patient survey so that we could learn about the patient perspective and expectation on their data security and privacy. We researched solutions from other industries, and we research current efforts of FHIR-based consent and identity resolution use cases. Next slide, please. And our patient survey showed that Almost 99% of respondents would like to be presented with a list of their health information that they can select and approve the health app to access. Almost 95% report that it was important for them to have a way to allow which information the health apps can access the information from the payer. And 76% said that it's important for them that the payer should monitor or be aware of what the health app wants to do with their information. So our result, despite of a small sample size, show that it's important for the patient to have a control of the data and to have a granular approach to consent what kind of information the health apps can access from their data. And I'm going to turn the next slide to Dea.
Thank you, Duan. The current CMS mandate requires the payers allow patients to access all of their data using any app of their choice. Thus, the consent implementation is very, very simple. Either grant access to all the data or deny access. But our findings indicate that the patients want to be empowered with better privacy and granular controls of consent process. Next slide, please. We looked at the finance industry, where Plaid-like platforms exist, and they provide better consent management capabilities. For example, Wells Fargo uses Control Tower, which is a way of allowing patients to access the list of applications they have consented to, and also to revoke the consent. Our findings indicate customers don't pay much attention to what kind of access do the apps have. In fact, some apps have access to the passwords of their bank account, and majority of the customers don't read the terms and conditions. Next slide, please. We found that implementing patient empowering granular control of consent creates various challenges. These challenges fall into two broad categories. First is the user interface and user experience during the consent workflow. Second is the technical shortcomings of the current standards and the solutions. For instance, the FHIR consent resource is not a best fit in some use cases, like capturing consent around advanced directives. The SMART specification, which is used for the third-party app integration, does not provide fine-grained interaction and search constraint on a resource. So let us explore some of these challenges and initiatives to overcome them. Next slide, please. If we look at the UI UX challenge, it is a spectrum of challenge ranging from oversimplified user interaction, like one-click accept or deny, as is the case with Apple Health, which is very, very simple, which, by the way, pushes cognitive burden to the education component of the consent workflow. And on the other end is the overly involved multi-level nested lists representing data hierarchy. This particular extreme creates UI UX cognitive burden in terms of drilling down in the list. Prime example is Ring Central consent process. This overwhelms the patient and possibly reduces the likelihood of them accessing the data using the third-party app. Therefore, some kind of a balance is required to increase the likelihood of patient accessing the data using the app of their choice. The second challenge is the terms and conditions. Currently, they are not human readable and not easy to comprehend. To overcome these and previously mentioned technical challenges, let us look at some of the standard solutions and initiatives under play. Next slide, please. Here are some examples of the standards and initiatives, and this by no means is an exhaustive list. These standards and initiatives range from being identity-centric to consent-centric, on all the way to shifting data ownership and control to individuals. In the identity space, these are centralized and decentralized, in the identity space, there are centralized and decentralized identities. The centralized identities are stored on a server that may support federated authentication along with different identity proofing capabilities. Further, using identity assurance levels, which provide certain level of guarantees, the centralized identity provider may join other providers in a network of trust framework, thus negating the need of identity duplication and paving way to a single and unique identifier at national or international levels and even across the industries. Then there are initiatives like the self-sovereign identity or sovereign, which shifts the control of identity ownership and attributes that make up the identity from administrative authorities to the digital wallets of an individual. Now you may notice that there's a fair amount of duplicated efforts between the different initiatives, mainly in the identity space. In the authorization space, Smart version 2 is defining finer grained interaction constraints and resource constraints using the search parameters. XACML is trying to do the same thing on the attribute level. Then there are initiatives in the consent space, which are trying to enhance the usage of the consent file resource. Mainly, the San Diego Health Connect initiative aims to enhance the consent file resource by testing implementations of various granular controls through the use of access and revocation policies. Then there is Kantara initiatives using the user-managed access tries to solve the challenge of terms and conditions readability by generating human and machine-readable consent receipt. Kantara also solves the problem of fine-grained access control using user-managed access and health relationship trust profile, which is called the HEART profile. And at the very far end of the privacy control is the SOLID project led by Sir Tim Berners-Lee, which is industry agnostic and aims to make individuals the owner and controller of their data. In a nutshell, an opportunity exists to capture granular consent, starting with the lowest cognitive burden on the end user, then storing all things related to consent on the FHIR consent resource for better interoperability. All of this while supporting emerging standards around decentralized digital identity and trust framework providers. The next slide. Aju, do you want to take from here?
Yeah, yep. So what did we learn so far? So one of the first things we learned is actually that the CMS Patient Access API does not require a level of granular consent outside of Smart, Auth, and OpenID Connect. We also learned all the various opportunities available for implementing a much granular level of consent that is not allowed on Auth and OpenID Connect. So if you look at the reality, payers are most likely going to be using their FHIR capability for use cases outside of the CMS mandate. And we just heard about like several of these innovative use cases, such as the advanced care planning from Kevin Williams, the social determinants of health from the SDOH team, and the Silver Tsunami use case from Dr. Grandison. So what this means is there are a lot of use cases out there that is much beyond the CMS mandate of Patient Access API. So I think, and we strongly think that these use cases will most likely require a much more granular level of consent. So to conclude, what we would say is we strongly recommend that payers and other FHIR implementers track and onboard new developments in the area of granular consent and be better prepared for these kinds of use cases in the future. Next slide, please, and I'll turn it back to Mike.
Thanks, Aju. So just wanted to, again, acknowledge all of those that supported us in this project. Again, Cambia Grove for providing us the opportunity to participate in the fellowship. All of our mentors here that guided us and gave us their expertise over the last 3 months, and all the other many experts that they connected us with around interoperability, FHIR, and importantly, consent. So thank you. That concludes our presentation.
Thank you, Mike, and thank you to all of the presenters for this great work. Okay, so we have a pre-submitted question as well as a newer question that are related. So let me get to the pre-submitted question first. folks are curious, what are your aspirations post-fellowship with all of these new learnings? You've obviously seen a lot, learned a lot. How do you plan to take it back home and implement to whatever extent you're able to?
Well, I'll start us off. I mean, it's no secret that I participate in projects that focus on the patient access API because that is so immediate. But overall, it was really an opportunity not only for me to get to know FHIR much better, get to collaborate with all these wonderful teammates of mine and our mentors, and really see what we can do to push us further. Go beyond looking at compliance and look towards the future. As Aju mentioned in our last presentation, FHIR is the future and it's here. And so payer, from my perspective as working for a payer, we need to embrace it and see what we can do more to help better, not only improve the care for the members that we cover, but then also see, using it to drive down costs. And it can't be overstated right now, given the COVID-19 pandemic. We need to be able to share data better. And so this is really, to me, it's a very, very important passion of mine.
Absolutely. Thank you, Mike. Does anyone else have thoughts to share on how you'll take this back home with you?
So yeah, I like to just echo Mike's feelings on bringing FHIR interoperability up to sort of the surface within the healthcare, especially on the clinical side. I know it's out there, but maybe not as visible as we would like it to be. So I think this is great as fellows to be able to bring that personal experience and just, bring it out, the availability of what FHIR can do on all sides of the medical care.
Great. Anyone else? No, that's okay. So I do have one question to read from the Q&A box. And before I get started doing that, I'll just say one more reminder to all of the attendees. If you have any questions for this last group, this is your last chance before we all drop off today. So please feel free to share them in the Q&A box at the bottom of your screen. But before wrapping up here with all of you, I would like to read the one that has been submitted. If other innovators wanted to join in this work or carry it forward, what advice or best practices would you offer them?
I think I can start on this one. I would say join the existing working groups and the initiatives, alliances. What the alliances are trying to minimize the duplication of work that has gone in the last decade or more. And so joining them is a very good starting point, and attending the regular monthly or the weekly meetings is a good way to keep in touch with what is going on. And also try to play around with the specification, try to play around with the consent resource and see it for yourself that does it fit your use case. And if not, then take it to the working group and try to nudge the enhancements, and that would be the way to go.
That's great advice.
Yeah, also I just want to echo what they just said. Since our paper would go public and accessible to everyone. Also in our paper, we provide some references of existing work related to consent. So that you can check out.
Great, thank you. And I would, oh, sorry, Aju, go ahead.
And I was going to say, there's also this, chat platform, this ULIP platform, the HL7 chat. So you can anyone can actually join and contribute, or even track all that's happening on the chat platform. So I think there is a channel for SMART. There is a channel for other consent frameworks as well. So that's a good plug actually into what's happening in the industry as well.
Fantastic. Those are great actionable ways that the community can get involved. Okay, so before wrapping, I have one question for all of you before we say our final comments here today. What would you see as the biggest opportunity in FHIR? What are you most excited about? It could relate to your most recent presentation, those you've done earlier, just in general. What excites you about this work?
I can start on this one. I think the interoperability is now, compared to two decades, even 1 decade ago, is much easier to accomplish. And this opens up so many avenues of innovation, especially with the CMS mandates, that we are just beginning to see the advancements that the other industries have already seen. So healthcare industry will just see this boom very soon.
I think I like the idea of bringing all these entities together, the patients and the providers and the payers, and bringing them all together in a language that they can all speak. So like the HL7, let's say the EDI and the external standards, only technical folks can speak that language. But FHIR is more REST based, JSON based. Anyone can actually speak that language. So that's a great opportunity. And even some of the previous use cases like the silver tsunami and the advanced care. So those are some real to life use cases that actually FHIR is enabling using this technology. So that's very exciting.
Yeah, I totally agree with what Ajul and Diana said. I used to work for a caring hospital, and currently I'm still working in a hospital where we can see a lot of fragmentation of information. There's no exchange of information between payer, providers, patient, and other on the health apps. So I think I see the most benefit of FHIR is it can bring all the information together, so it can lead to much better quality of care. Because without the consistent information, it creates a lot of waste, a lot of redundant tests that could be conducted again and again because there's no exchange information, and the patient are not able to access the data for their own healthcare, and there's no connection between the providers and the community group as the social determinant group was talking about. So it's what I'm more excited about FHIR.
Absolutely, we agree.
Yeah.
Okay, go ahead, Mike.
Oh, I was just going to say, I just totally agree. I think the exciting thing for me is, for both of projects, the amount of work that's being done in this FHIR space and landscape is huge. And I think the amount of brain power and efforts like Da Vinci and Karen Alliance and everything else that's going into it right now means, just the momentum is huge. And I think it's just going to explode, as Dia said earlier. It's just really on the, it's where we're all going and where we need to be. So.
Absolutely, and a call to action for the participants on the call today to get involved and be part of this movement. We really are on the precipice of something very exciting. Wonderful. Well, thank you all again so much for your presentations and for all of the hard work that you've done. We'll just say a few comments before we wrap up here today. Thank you again to all of the fellows who have presented with us today, our partners, the mentors, and the audience for your participation and attendance. There are a few additional ways to get even more connected with this community and with this work that I would like to just list out here very quickly. First and foremost, please visit the fellowship page on Cambia Grove's website for more information about each of the fellows, their projects, and to access their contact information if you would like to get in touch with them directly. Please also take a look at Cambia Grove's calendar for a few roundtables that we have coming up next month to discuss interoperability even further. Finally, please check out UHIN's HIT conference on November 10th to hear even more from Fawn Matthews and Mike Barabee. And finally, as a reminder, we did record this session and we'll share a link including a post-show write-up. So if you missed any particular section that you would like to revisit, we will have that to you very shortly. So with that, I would like to say one final thank you to our fellows for your incredible work, to the audience for your participation as well. We look forward to remaining connected with each of you through Cambia Grove in the future. Thank you and have a great day.
Thank you, Julia, and thank you, everyone.